I'm happy to give the floor to the emerging voice of Seye Abimbola from Nigeria.
So what I really want to do is to take you through a journey, so a thought experiment to consider a setting, an imaginary country that doesn't have a health system at all, and how you might go about building a health system for that country. And that's the title of my talk, Reflections on the Non-Existent Health System. I want to do this within the framework of emerging realities all over the world. You think about chronic diseases taking the floor. You think about informed patients, choosing the balance of power between patients and healthcare providers. You also consider the advent of increased aging in populations. And you think about risk factor management sort of taking over the scene from disease management as it used to be, and how long-term management is taken over from acute and inpatient care. And it's also important to highlight here that chronic disease generally kill more people, actually kills twice more people than all the vector diseases put together, and this includes malaria, tuberculosis, and HIV/AIDS. So there's a huge issue here, especially for our health systems, and we need to think afresh, think anew from new realities, and not depend on old systems. And recently I was asked to give a talk about the Nigerian health system, and what I did was to ask my colleagues back home in Nigeria this same question, ask them to think that Nigeria doesn't have a health system, and how they might go about building one for the country. And I got quite a range of responses, and I sort of pulled them into three pockets that I will talk to you about. The first range of responses had to do about distributive justice. And someone made reference to this quote by Julian Hart, who said that the availability of good medical care tends to vary inversely with the need for the population served. And someone made an example of a tertiary hospital in Nigeria that had a world-class renal transplantation facility without suctioning machines in the children emergency wards. And second pool of responses has to do with strengthening primary care and how we need to re-emphasize healthcare by introducing community-based care. Presently in Nigeria, about 70% of our healthcare budget goes into tertiary care, and this is crap. So the third pool of responses has to do with the role of medical doctors within the health system. And people ask questions about what should be the role of doctors in this new healthcare system, given that the prevailing trend in diseases have changed or are changing from this acute care where you need doctors, big doctors, to long-term care where you might just need the use of just community-based interventions. And one of the things that this thought experiment did for me as a person, and might do for you as well, is to step back from the system and imagine the framework that holds society together. And in the case of Nigeria, two things popped up. Mobile telephones and patent medicine vendors. And one area where mobile telephones might be very useful is the area of cardiovascular emergency management. There's a study from Africa that showed that there was a delay of 1 week between symptoms and arrival at ER, and more than 20% of patients died. And this is something that mobile telephone could bridge very easily, because we have 50% penetration in Nigeria, 80 million subscriptions, 7 million quarterly increase in subscriptions. So this is a huge market, it's a huge idea to explore, especially to reduce emergencies and to better manage patients on a long-term basis. And all over the world, mobile phones have been used and tried to help patients adhere to medications, to remind them of appointments, to monitor them, their progress, and for self-management. And these are sort of ideas that we might want to play around in thinking about this new health system. How might these be better adapted to current realities? And I've sort of put forward a research proposal to look at how remote consulting with chronic disease, in terms of chronic disease, could help cost-effective strategy for managing risk factors, and to reduce emergency presentations, improve care for remote patients, and reduce patients with both in primary care and tertiary care. And second pool of ideas that might also help to shape this new health system is the role of informal providers in the healthcare system. In Nigeria, patent medicine vendors, otherwise known as chemists or pharmacists, untrained, are the primary healthcare providers in the country. Now, they're easily forgotten, easily ignored, but they are there and they are at the center. And if you go back to the Alma Ata Declaration, the whole idea of primary healthcare was that primary healthcare essentially is the first point of contact for people. And if this is the first point of contact, we start thinking about how we might integrate them into the main body of the health system and better adapt their use or their activities within the health system. So back to the thought experiment. How might this new health system differ? What are the features that might differ? What do we do with the doctors that we presently have? Do we just kick them off? Nigeria presently trains so many doctors that we can't even employ all the doctors that we train. So it's a big issue, and we start thinking about cost-effective strategies of training healthcare providers. And should hospitals remain at the center of healthcare systems? Should they just be pushed to the periphery? And these are also issues to consider because long-term care have taken over the show from acute and inpatient management that we've been used to, and that our health systems were built to manage. And there was this quote by Bob Kane, who said the epidemiology of disease presently is absolutely out of sync with the health systems we have. We practice 19th century medicine in the 21st century. And there's a huge need for us to start thinking about how we might restructure our health system. And this is not just about developing countries, it's all over the world. This is a new reality for everybody. And the important point I want you to go home with is that we in developing countries have an advantage here. We have health systems that are not so structured, so perfectly functioning, so ossified, that cannot be changed. And research to change these health systems, to modify their functioning, will be very important both for us and also for the developed world. And here I'm asking us to turn the world upside down, to reverse the direction of information and innovation. And again, when we're going back to your countries and to your desks and to your situations, remember that it might be very useful for you to think, step back from your health system, imagine that there was nothing there, and it might help you go forward in thinking about new things to adapt your system to. Thank you.